Hi everyone, welcome back to another episode of Ask Dr. Nick. My name is Dr. Nick Schmidlkoffer and I work for the Neurologic Wellness Institute here in downtown Chicago. And on today's episode, we are going to answer the question, is my dizziness coming from Bppv? And Bppv is termed Benign Paroxysmal Positional Vertigo, and it is the most common cause of vertigo or dizziness. And it's generally more common in females, and it can occur spontaneously, especially in the older age, but then it also happens a lot after head trauma. And what's happening is, or if we think about the name, it's benign, as in this dizziness happens and it's relatively benign, as in it's going to cause a lot of maybe nausea, feeling dizzy or spinning, but at the same time, it's something that's happening in your inner ear that can generally be fixed very easily. Benign paroxysmal meaning that it kind of comes and goes. Positional, meaning it's coming and going with head position, turning or side bending, getting out of bed, different positions like that. And then vertigo, as in we're actually feeling a spinning sensation of ourselves or of the world around us. And so we're going to talk about an older paper that kind of like generalizes Bppv, shows how it can be diagnosed relatively easily, and then treatment for it. Okay, and I'm going to talk a little bit about the more of the pathophysiology, more of what's actually going on in the inner ear, and the reasons for it. Okay, so let's first go to what it is. So we'll share this screen. Okay, so here is the inner ear. So if, let's say, your eyes are right here, your nose are over here by the cursor, this is the inner ear, and this would be, let's say, someone's right ear. And so here's the auricle. Then you have the ear canal going into the middle ear. The middle ear has a couple bones that help to transmit the sound from the eardrum to the inner ear. And then the inner ear has this bony piece that contains a cochlea for hearing, contains a vestibule for more gravitational sense of movement and where you are, or linear translation with head tilts. And then here we have the semicircular canals. There's 3 of them, a horizontal, a posterior, or let's do this, a horizontal or lateral, a posterior or inferior, and then this top one is a superior or anterior. So there's multiple names for all of them. I may use them interchangeably, and I'm sorry for that. And so these are more for rotational sense. Okay, so like when you're spinning or when you quickly turn your head to one side, you know that you're turning even with your eyes closed because of these vestibular sensations. Okay, and this is connected to the vestibular cochlear nerve, or cranial nerve 8, that goes into the brain. Okay, so we're just going to kind of dissect this area right here. So this is, again, the most common cause of dizziness. And so here again are the semicircular canals. Okay, superior, posterior, lateral, or horizontal. And here is the vestibule that is more for that gravitational sense. So let's look at the vestibule first. You have basically the saccule and the utricle, and these just sense different types of gravity. Okay, and how they sense it is that they have this membrane that has these little hair cells on it. These hair cells are going to sense this translation in different ways. And this membrane is called the photolithic membrane, and these little crystals made of calcium carbonate called otoconia are going to weigh down the membrane. So by weighing it down, when you tilt your head, this membrane slowly goes to that direction. When you translate, let's say this way, the otoconia, that membrane, is kind of sitting, and then it drags behind, and that's how you get that sensation. Okay. On the other side, we have these semicircular canals, and at each little ampulla here, this little outpouching, we have this crista ampullaris, with this membrane is called the cupula. And so there's fluid in this purple area, fluid that is going to move when we move, and therefore that fluid is going to deflect the cupula and tell us if we are moving to the right or the left, back, forth, whatever it may be. So what happens in Bppv, or benign paroxysmal positional vertigo, is that these crystals become dislodged off of the membrane. These calcium carbonate crystals get lost, and they get caught into one of these canals. Most commonly, it's the posterior canal, because the posterior canal it's a lot easier to kind of get up here and then to fall down and not get out, okay? And so if you can't get it out, then it constantly sits in this lymphatic fluid, this endolymphatic fluid, and therefore causes this drag. And therefore, every time you turn, your body or your brain is getting a sensation that is not normal. There is either too much stimulation because of this excess drag. And so the posterior canal is most common at around 70% of Bppv cases. Then the horizontal or lateral canal is next at like 20 to 30%, and the superior canal is more like 5%, or the anterior canal. And that's because it's really hard to get crystals caught in here and then somehow not fall back out, because it's just so how the gravity, how it's positioned, it's really hard to get them caught and not have them just fall out spontaneously. Okay, so again, crystals get dislodged and get caught in one of these canals, most commonly the posterior canal. Okay, so now let's go to the paper. So again, this is an older paper. It's a review article, Benign Paroxysmal Positional Vertigo, the history, pathophysiology, some office treatment, and future direction. It's from 2011. Okay, and so we're mostly just going to talk about the abstract here, and then look at some of the graphics. So Bppv is the most common cause of vertigo. As I said, spontaneously can occur in ages 50 to 70, more common in females though. In younger individuals, it's more due to head injury. I think this the spontaneous connection can actually go all the way to maybe like 30 to 70 years old. The wide spectrum of severity, it's generally provoked by any head movement. So any head movement can cause symptoms. Again, symptoms are this rotational vertigo. It can cause falls, especially in the elderly. So Cardinal Features, there's a diagnostic test we'll talk about called the Dix-Hall Pike. Again, they're attributed to these detached otoconia, those calcium carbonate crystals that go into the semicircular canals. Now, Bppv symptoms can resolve spontaneously, like without doing anything, they can resolve. But it might take days, it might take weeks, it might take months, it might take years. And during that time, the brain is getting input that it shouldn't really be getting. You're having symptoms, and that brain input is trying to, your brain doesn't want you to feel dizzy and out of place. So it's constantly trying to change that input. And then all of a sudden you eventually get it fixed, and then it may actually take some time to rechange the brain, to retrain the brain back to your normal self. So this is why it's so important that if you have dizziness, to get in to see somebody who can treat Bppv. PTs, especially specialized PTs that know how to treat it. Chiropractors or specialized chiropractors, stuff that we do, can really help to get rid of these symptoms fast and prevent the longer lasting effects. Diagnostic strategies and the simplest office treatment techniques are described here. Okay, so they're actually looking at how you can treat it at home. I'm gonna say right now that even if you think you have it or you've had it in the past and you get it again, trying to treat it at home might not be the best idea, because you can convert something that's very simple into something that is now more complex. And so again, if you find a practitioner that you like and that can treat it, go in and see them. It's generally a very easy treatment, and that very easy treatment can keep you out of misery for longer days, and it can be very, very simple, okay? And so let's just talk about Bppv. Here's another picture of that semicircular canals and the ampulla. where the crystals get caught. So right here, figure 2, this is the Dix-Hallpike test. And so what we are looking at as a practitioner is we are taking your head back and to the left or back and to the right at 45-degree angles to look for nystagmus and any symptoms. And so the head has to be hanging off the table or off a pillow, like in this case, and we are looking for nystagmus. And so this is for a left posterior canal. Again, posterior canal is 70% of the cases, and this is just showing the connections from that posterior canal in through the vestibular nerve to the different nuclei, okay, in the brain stem, and how it connects to the different eye muscles through their neurons that are in the brain stem, okay? And then what that is going to cause, in this case, a left ear, a left posterior canal Bppv, is when the practitioner takes your head back, your eyes are going to drift down and to the right and then beat up and left. So a torsional upbeating nystagmus, as in they drift and they go fast up and left. And that drift, that eye movement, is what causes the feeling of motion sensation, okay? This may last when you're down there for 30 seconds. It may last for a couple seconds. It really just depends. And then this is what allows us to treat it properly, and then by identifying it, and then after treating it, to recheck. Again, it can be a pretty easy treatment. In order to test the horizontal canals, okay, where rather than taking the head back on a 45, we are looking with the head straight, either turn to the left or turn to the right. And again, we're looking for a specific nystagmus, okay? If head's turned to the left and it's a left horizontal canal, we're going to get nystagmus that is beating down towards the floor to the left. That is called geotropic nystagmus, okay? Versus that is the most traditional canal lithiasis, as in the crystals are caught in the canal and they're just moving. Now, if the crystals are attached to that membrane, that cupula, it's called cupulolithiasis. This means that it could be a little bit harder to treat because it's attached to the membrane. It's not free floating in the lymphatic fluid. And so therefore we're going to get a little bit of a different sensation. So turning your head to the left, the nystagmus is going to go the opposite direction, up away from the floor towards the ceiling. And at the same time, that would be maybe where you get the symptoms the most, if it's a left horizontal canal, cupulolithiasis. And then a superior or anterior canal, again, very, very uncommon. Basically, you test it the same way that you test the posterior canal, with the head back and the left on a 45, but rather than getting nystagmus going down and up and to the left, you're going to get the opposite. It's going to go up and left and beat down, up and left and beat down. And so that's just, if you're seeing a downbeat nystagmus, that's what it's going to be. So this is kind of what you should expect when you think you have Bppv, and you're going to see your practitioner and they're going to test for it, okay? How do we treat it? Well, there are a couple different ways. Here is one way called the Semont maneuver. Semont maneuver, it's basically where you get thrown down to one side with the affected ear down, and you get thrown back to the other side with the head in the same position, and then you come back up. That's one way to treat it. I know a couple PTs that do that, especially if they think it's more of a cupulolithiasis. How we treat it here, I treat it here, is mostly using the Bppv maneuver. The Bppv maneuver, basically we go back down into that Dix-Hallpike position, exactly the same, wait for nystagmus or symptoms to go away, then we turn the head 45 degrees the other direction, then we get you on your side, turning the head even a little bit more, again waiting for all the nystagmus or the symptoms to go away, and then lastly, sitting back up. A lot of times, one Bppv maneuver can be the trick, and you may feel a little bit off for a day or two, but otherwise symptoms are gone. Sometimes it takes 2 or 3 or 4 Bppv maneuvers if it's a true posterior canal Bppv. And then, again, if you've had it for a while, let's say a week or a month, the brain may have started to change and adjust around that. So it may take a little bit longer to change and readjust. You may still feel off after getting treated, but you don't necessarily have the symptoms when turning your head, okay? And so then lastly, they kind of talk about different ways you can do it at home. Again, I'm not a huge fan of testing and treating at home, just because you may change things and make things worse. And lastly, the barbecue roll is for horizontal canal Bppv. And so let's say if it's in the left ear, you just start with the left ear down, turn your head to the center, to the right, then straight down, and then you end up in the same position. It's called a barbecue roll for horizontal canal Bppv. And so this is kind of what you expect if you think you have Bppv, how it should be tested and how it should be treated for the patient, okay? And that is for superior canal. Again, very uncommon, but relatively easy to treat. So I hope you guys enjoyed this one. Bppv is super, super common, and I think everybody should have a good practitioner that they know that if they have it once, they can always go back to them. A lot of people are going to go first to ENTs. If they feel any dizziness, they may get some drugs or medications to take away the dizziness. But a lot of times, like I said, the most common cause is Bppv. And so to have somebody to go to as fast as possible can be very helpful, and to get rid of it as fast as possible. So you're not making other challenges or changes in your life, and you're not restricted from any of your normal daily activities. So I hope you guys enjoyed this one. Thank you, and have a great day. Stay healthy.